Okay, hello, everybody. So I am Dr. Sean Baca. I am chairman of advocacy and legislation for Palm Beach County Medical Association and past president. We are recording this session, and we hope that everybody who wasn't able to attend tonight will be able to watch this. But we have some very interesting, important things that I think pretty much everybody needs to know, whether you're a physician, a politician, or the public. So we all know that drug pricing is a big issue in this country. We pay probably 3 times as much as people pay in other countries. But what people don't understand is it's a very complex web that basically creates these issues. And this will be quite an eye opener for a lot of people tonight. So what I wanted to do is introduce Dr. Bob Levin. Robert Levin is a rheumatologist. He is past president of Florida Society of Rheumatology. He's definitely one of the good guys. And he volunteers lots and lots of times to basically help other doctors practice medicine and help patients by being able to get prescriptions at an affordable price. He's currently the president of ATAP, which is the Alliance for Transparency and Affordable Prescriptions. So with that, we're going to leave it to Dr. Levin. Thank you.
Well, it's first of all, I'd just like to say thank you to Dr. Baca and the Palm Beach Medical Society for giving me the opportunity to talk about some very important topic that really affects our patients and our practices. And that really is drug pricing. And I think that's really a function of the drug supply chain, which I'm going to be discussing during the next few minutes. This is something that has really been an interest of mine going back probably at least 5 or 6 years. As we noted, in rheumatology especially, we have lots of patients who need specialty medications. And those specialty medicines, unfortunately, come at a very high price tag. And what we've observed over the past 10, 15 years is marked inflation of the list price of these drugs. It's very easy to blame the manufacturers for this. And I'll have to say just right off the bat that I'm not here representing the manufacturers, and I'm certainly not here representing the PBMs or the pharmacy benefit managers or the middlemen. But the manufacturers have increased prices, and some of that has gone to increase profits. But a lot of it is a function of how the whole drug supply chain works. And to understand how this works really can explain why the drug prices have skyrocketed in the past 20 years. At the beginning of the biologic era for rheumatoid arthritis, there were a couple of drugs, biologic drugs, the first 2 on the market that came out around the year 1999 or 2000. And those drugs were Remicade and Enbrel. And when Enbrel first came out, it came out at the what sounded like the exceedingly high price of around $900 a month. Well, fast forward to 2022, and the price for Enbrel is way north of $6,000 a month. And you would think that the manufacturing costs, yeah, there's inflation, and we know that inflation's been a bigger problem in the last year than in other times during the last 2 decades. And we know, but inflation does not explain the increase in prices. Really, I think that it's so easy, like I said, to blame the manufacturers. Yeah, those greedy manufacturers that are increasing prices and therefore increasing bottom line. But the truth is that most of this, in my opinion, is being caused by the middlemen or the PBMs. So let me get started with this. If I can get this to move, that would be great. Oh. See if I can get this to work better. Well, here we go. Now it's working. So let's talk about PBMs, or pharmacy benefit managers. So what are PBMs? And their pharmacy benefit managers are companies that manage prescription drug benefits on behalf of health insurers, Medicare Part D plans, large employers, and other payers. And they develop and maintain lists or formularies or preferred drug lists of covered medications on behalf of these insurers, which influence which drugs individuals have access to and determine the out-of-pocket costs. So using their purchasing power to negotiate rebates and discounts from drug manufacturers and contract directly with individual pharmacies to reimburse for drugs dispensed to beneficiaries. So let's look at that third bullet point of use of purchasing power to negotiate rebates and discounts from drug manufacturers. Really, this is at the crux of the specialty tier medications, such as Enbrel and Remicade that I had talked about on the last slide. What happens is that there are a number of drugs for the most common disease, the inflammatory disease that I see, rheumatoid arthritis. And so the preferred drug list is really something that's made up by the PBMs, and basically it's who's going to pay them off by giving them a rebate or a kickback the most. And we'll talk about that on future slides. But the key is that this is a profit-driven machine for the PBMs, and that has forced wholesale and list prices up. So what is the role of the PBMs? Initial purpose when they came into play back in the 60s and 70s was purely administrative. So they were keeping track of medications and making sure that dispensing was accurate. So as drug costs continued to rise, PBMs offered more services that promised health plans less expensive drug programs and lowered costs. Now they handle everything from negotiating price concessions with manufacturers to creating pharmacy networks to determine which drugs are covered by which plans and where the patients can obtain their drugs. So PBMs have played a critical role in administration of prescription drug plans. However, over the past 10 years, the PBM marketplace has transformed a great deal. And these changes include both horizontal and vertical integration among health insurance companies, PBMs, chain pharmacies, specialty pharmacies, and long-term care pharmacies. So this, resulting from this, a smaller number of large companies now wield nearly limitless power and influence over the prescription drug market. So this schematic, or this slide, really shows the integration of insurer, PBM, specialty pharmacy, and provider services. And you can see the big players, that the insurers that we're all familiar with: United Healthcare, Aetna, Cigna, the Blues, and Humana. And you can see that they all work or have PBMs as part of their organizations. And in fact, United Healthcare, Optum, has been a subsidiary of United Healthcare from the get-go, and that's been present ever since that I became aware of PBMs, and that goes back probably close to a decade. I think many of us remember when CVS bought out Aetna, and so now these two are one and the same. And you can see that CVS, which is the largest pharmacy, they have a specialty pharmacy, have clinics, and they also have obviously retail pharmacies. We're all familiar with Express Scripts going back many, many years, but Cigna bought out Express Scripts, and Accredo is their specialty pharmacy. And so these are, again, one and the same. These companies are one and the same and have become behemoths. And sort of like the monopolies way back in the early 20th century and late 19th century, they have unlimited power in terms of the marketplace. And you can see that Anthem, Humana, and just the Blue Cross Blue Shield consortium have all sorts of, have PBM associated associated affiliations and specialty pharmacy associated affiliations. The key is that these are integrated systems, and it's now become much more difficult to get anything done in terms of any reform. Hopefully, there will be something good happening on the horizon in the near future, which I'll get to. So who are the PBMs and what is their market share? And if you look at this slide, you see the top three: CVS Health with Caremark, Cigna with Express Scripts, and United Healthcare with Optum Rx. And then those, if you look at the top three, they control nearly 80% of patient population, or 180 million Americans' prescriptions in 2021. And then the rest of them make up the other 20% that you can see on the slide. Numbered 4, so if you look at the top three in terms of Fortune 500 list, CVS Caremark is number 4, Optum Rx and UHC 5, and 13 Express Scripts and Cigna. I think that speaks for itself. Really, if you think about it, what do PBMs actually produce? What kind of research and development do they have? What kind of services do they provide? And I will contend that it's very little. So this slide is really the crux of this drug supply chain. And if you look at it, and I don't know if you can see my arrow, but the PBMs, which are right in the middle here, interact with just about every facet of the drug supply chain. So if you look, the plan sponsors, which represent employers, union, government programs, contract with PBMs to manage their pharmaceutical benefits. And manufacturers have to go through the PBMs because the PBMs set the formulary or the preferred drug lists. So the PBM basically, with the manufacturer, they all bid for placement on the formulary. In rheumatoid arthritis, you basically want to be the top tier drug as a brand name drug. And if you're not on the formulary, you have no access to the market. So access to the market, being on the formulary, really has to do with market share. It has to do with the amount that is rebated or kickback from the manufacturer to the PBM in turn for drug placement on the formulary, which gives market access. So basically, the PBMs have the manufacturers over a barrel. The PBMs also own their own pharmacies, and they interact with other retail pharmacies and other specialty pharmacies to provide prescriptions for the patients. And so the PBMs, with their contracted pharmacies, for example, CVS Retail Pharmacy, CVS Caremark Mail-Away Pharmacy, and CVS Specialty Pharmacy, they give better deals to those pharmacies than they do to others. And in fact, the PBMs have had a dramatic effect on the pharmacy business, and many independent pharmacies have gone out of business in our state because of bad PBM practices. So the patients obviously get their drug from the pharmacies, and the patients get their benefits through the plan sponsors. And that's really how the system works. So why is this important to know? The supply chain impacts your practice in patients by choosing profits over affordability, access, and efficacy. PBMs use the supply chain to their advantage by directing patients to the drugs that makes them the most profit, rather than not necessarily what you think or what the patient might think, or with shared decision-making, what might be the best choice for that patient. And they accomplish this through several mechanisms. There's rebates, which I'll talk about, utilization management, which we'll talk about, spread pricing, which we'll talk about, and then there's copay accumulator programs and maximizers, which also increase profits for the PBMs and the insurers. So let's talk about rebates for a couple of minutes. So rebates are basically a percentage of the list price of the drug that's paid to the PBM, as in turn, the PBM will afford the drug that gives them the most rebate, the most money, as placement on formulary. It really has nothing to do with placement on the formulary. It has nothing to do with safety. It has nothing to do with efficacy. It has nothing to do with mechanism of action. It really just has to do with which drug is going to give the PBM the most rebate. And so how the rebate is calculated is you take the list price, you multiply that by the percentage of rebate or the percentage of discount, and then you look at the market share or the number of prescriptions filled. And so basically, for a biologic drug that's $6,000 a month, which is not an uncommon and not an excessively high price as the prices go, and let's say the rebate is 50% of the list price, then the rebate per unit sold or per annual rebate is $3,000 that's paid per prescription to the PBM. And then if you multiply that by the number of prescriptions or the percentage of the market share, then you get an idea of how the PBM can decide which drug is going to be the preferred drug, is which one's going to give them the most money. It's, like I said, not related to efficacy, safety, or mechanism of action or any other characteristic of the drug. So if you look at the drug manufacturers, it's like a bidding war. It's like an auction. Whoever sells the drug, gives the highest rebate, is the one that's going to get the placement and therefore get market access. It's kind of different from when you, let's say you are doing a, you're doing a construction job, remodeling your house. And you would say, okay, I'm going to remodel this bathroom. And we're going to get several bids from reputable construction companies. And whichever reputable construction company comes in at the lowest bid, that's the one you're likely to take as long as you feel like they're going to do the job. So that kind of competition actually leads to the lowest price. Whereas this type of auction setup, where the PBMs are basically putting all the manufacturers in competition, that drives the prices up. So let's think about this. If you increase the list price and you pay the same percentage rebate, there's more money that's going to the PBM. So actually, I think this rebate system actually puts upward pressure on the list prices of drugs. And so some of the inflation is actually caused by the upward pressure by the rebate system that causes drug prices to go up. And guess what? Our patients pay their co-payments and their deductibles off the list price of the drug, not off the net rebated price of the drug. So my patient who has a $6,000 prescription per month is then going to go to the pharmacy and there's a 50% rebate on it. They're not going to be paying their 20% copayment off of $3,000. They're going to be paying their 20% off the $6,000. And that's one of the reforms that we're really pushing for, is that rebates, if there are rebate system, these rebates should be passed through to the consumers. And that's something that we're pushing for in state legislation. So if you look at this graph, and I would just look at the blue bars, forget the red line. The blue bars show you the total value of pharmaceutical manufacturers' rebates, the total rebates in billions going from 2014 to 2019. And you can just see that the amount keeps going up and up and up, and the numbers for 20 and 21 are even higher. So this is just something that this system is out of control, and I think is putting upward pressure on list prices of drugs, which is definitely affecting the affordability of our patients to be able to get access to the treatments they need. So in 2017, prescription abandonment rises as patient out-of-pocket costs at the pharmacy increases. And so what you're looking at, the percentage of patients abandoning new prescriptions on the y-axis, And you can look at the copays of the patients going upward on the x-axis. And if you look on the right at a copay cost of more than $250 a month, or $250 for that prescription, a full 69% of the patients abandoned their prescriptions. Well, if you look at my patient example, $6,000 a month for their list price of their drug, and they have a 20% copay after they met their deductible, their out-of-pocket is $1,200. How many of your patients, I know very few of mine, can afford a $1,200 a month copayment, but that's what they're facing. And so it becomes, drug gets approved through the prior authorization and step therapy process, but then the patient has this massive out-of-pocket expense and can't afford their drug. So PBMs claim to save billions for our healthcare systems. They design formularies based on negotiated discounts, and it's a secret kickback packages based on list price and market share. They have utilization management tools. They keep patients on the most profitable drugs, and many employers have no idea what they're signing when they sign contracts that include these utilization management tools. More affordable pharmacy channels. They claim that they have more affordable ones. Well, they're just more profitable because they're part of their own system. And encouraging use of generics and affordable brands, that's really bogus also, because the bottom line is that higher prices and higher price brand name drugs are oftentimes the preferred drug over lower price generics, because again, these are rebated, and the higher the list price, the bigger the rebate, the more money that the PBM makes. So let's now move on to utilization management. And so now that rebates have been established for preferred formulary status, PBMs must direct patients to those drugs. How do they do it? One is step therapy. They require patients to try and fail the preferred drug based on profitability for them. Number two, non-medical switching. That changes in formulary to new preferred drug during the patient's plan year, even if the patient is medically stable on their current drug. And then prior authorizations. And prior authorizations really are that they require that the drug get a special authorization before the insurance will actually cover their percentage cost of the payment for the drug. So prior authorization and step therapy are the enforcement tools for the rebate system. And non-medical switching oftentimes occurs during the plan year if the patient's drug is then switched off of preferred drug and the patient has to switch. That's actually terrible medicine, and it's been shown in studies to be deleterious to the health of the patient, oftentimes leading to more office visits, more costs, more hospitalizations, more infections, and that's all been documented in the literature. So the other main way, but there are more, but the other main way that PBMs profit is spread pricing. So this is actually, back a few years ago, was the largest revenue source for the PBMs. And so what happens is the PBMs basically have two price lists, one price list for the pharmacy and one price list for the payer. And the PBM keeps the two in confidence, and so the payer doesn't know what the pharmacy is actually acquiring, getting paid for the drug. So in this example, if you look, the PBM is charging the payer $20 for the generic prescription, but only paying the pharmacy $12 for the same prescription. So the PBM basically keeps the spread, or keeps $8 from the prescription. And so sometimes these spreads are much higher than $8 per prescription, and can be astronomically high. In any event, the pharmacy then gets the drug from the wholesaler for $10. Patient then buys the prescription for $12, leaving $2 as a profit for the pharmacy. So spread pricing basically depends on secrecy. So the pharmacy can't see what the PBM got paid, and the payer can't see what the PBM is paying the pharmacy. And so the spread pricing is a really great scheme to extract money out of the system. And then there's copay accumulators and maximizers. So copay accumulators, basically what's happened in the commercial market is that because of the huge copayments that a patient has to make to meet their deductible and then meet their out-of-pocket maximum with a 20% copayment on many of the specialty medicines that are prescribed in rheumatology and other specialties. The manufacturers and other charitable organizations offer copayment assistance. And so these manufacturer funds or these charitable foundation funds assist the patient in their copayment and allow the patient access to the medicine. Otherwise, the patients would have no access because they couldn't afford their cost share. So these copay cards have a maximum value. And once that's reached, then the patient then would be wherever they are in their out-of-pocket spend, and then they can go on and either pay their till their out-of-pocket max is met. Well, an accumulator, what happens is the insurer says that none of this money that came from some other source than yourself counts towards your deductible or your out-of-pocket maximum. So once the copay card is exhausted, then the patient is told when they get to the pharmacy, or that it's a mail order pharmacy, that that'll be $6,000 for this month's drug, because none of the money that was spent by somebody else counted towards their out-of-pocket max or their deductible. So then the patients are faced with either paying that deductible, which oftentimes is $6,000, $7,000, and family and out-of-pocket maximums are oftentimes 13,000 plus. So these accumulators, basically, they collect the money from the, let's say it's a pharmaceutical manufacturer, then they charge the patient again for the same thing. It's double dipping. And so these have been come into play in the last few years and have become more and more prevalent. And basically they're collecting 2 deductibles and 2 out-of-pocket maxes on the patients. So that's an accumulator program. Many states so far have introduced legislation, and a number have passed legislation outlawing accumulator adjustment programs. Maximizers are another variation where basically there are these companies out there that investigate copay cards that are coming from the manufacturers. And let's say a manufacturer's copay card has $15,000 value on it. They will make sure that the money is spread out throughout the entire year, so that these out-of-pocket obligations that are paid by these copay cards are maximized and all the money is extracted. Even if the patient has met their deductible and met their out-of-pocket max, they will make sure that the money is extracted completely from these cards, even when it's not needed. And so these are a newer variant and are problematic just the same, because these programs for copayment assistance from the manufacturers were basically allowing our patients to get drugs that they otherwise could have no access to because they can't afford their cost share. And these programs have made it, especially the accumulator, so that the patient can't stay on their drug through the entire year. It's a terrible thing. And what's the prevalence of these programs? So what you're looking at is copay accumulators on the left and copay maximizers on the right. And what you can see is 18, 20, and 21, you can see the prevalence of these, their use in commercial insurance, and they're implemented in plan design in the dark blue, and available in plan design, but not implemented in the light blue squares. You can see increasing prevalence of both of these types of plans, and especially in 2021 with increase in the maximizers. These are problematic, and there are other even more sinister plans that are being implemented as we speak. So what's being done to combat the PBMs? And I'm the president of the Alliance for Transparent and Affordable Prescription. This is a coalition of 23 patient and provider organizations working at both state and federal level, who have joined together to address pharmacy benefit managers and their impact on prescription drug costs and patient access to affordable treatments. And so the strategy of the Alliance for Transparent and Affordable Prescription is track legislation and at the state level, legislation, and also regulatory actions at the federal level, as well as a communication strategy. And we've been successful, and I'll show you that on a slide to come. There are other organizations, many other organizations that have been trying to do something about the PBMs. Certainly the pharmacists, the Community Pharmacy Association, nationally and in the state, have been quite active in trying to fight adverse PBM actions and policies that are hurting their businesses and causing major disruption in their ability to provide services. I know the American College of Rheumatology, and I know the Coalition of State Rheumatology Organizations have both been very active in the PBM world. And I just want to give a shout out to all of the efforts that the CSRO especially have been doing. I am also on the board of directors of that organization. And there's been a lot of good work that's being done. One thing that happened over the summer that was good, really good in our state, was that Governor DeSantis signed an executive order to hold the PBMs accountable in July. This directed all executive agencies to include provisions in all future contracts and solicitations with PBMs services that include the following: prohibit spread pricing for all PBMs, prohibit reimbursement clawbacks for all PBMs, and that really affects the pharmacies mostly, because after a pharmacy gets paid, then there's a clawback that can take away some or all of the small profits that they're getting on their prescriptions that are regulated through the PBMs. They direct agencies to include data transparency, and this is key, and reporting requirements, including review of all rebates, payments, and relationships between pharmacies, insurers, manufacturers, and directs all impacted agencies to amend all contracts to the extent feasible with these same provisions. I was interviewed on the news a couple of times the day this came out, and gave comment on this. So what's being done to combat the PBMs? ATAP, Florida Society of Rheumatology, the CSRO, ACR, all submitted comments to the Federal Trade Commission. The Federal Trade Commission has embarked on a comprehensive study to evaluate PBM practices. And now the FTC is doing this inquiry and looking also at the impact of the vertical integration of PBMs on the access and affordability of medication. And so I think this is something that could really be helpful and bear fruit, but this is going to take a while. What the FTC will do is likely they will have some recommendations for Congress to pass legislation that will influence this monopoly power of the PBMs and the insurers, and also other practices that they are doing that will regulate other practices that will influence their activities. The ATAP filed 2 amicus briefs. One was in the Eighth Circuit Court of Appeals in a North Dakota case, PCMA versus WeBuy, and PCMA is the lobbying organization, the advocacy organization for the PBMs, and Rutledge versus PCMA, which was in the Supreme Court, which resulted in favorable outcomes. And basically what those two, without getting in the weeds too much, what these two cases were about was that states don't have the right to regulate plans that are employer-based or come under the heading of ERISA plans. And so these two, the state of Arkansas with the Rutledge case and the state of North Dakota with the WeBuy case, what happened with those is that the state claimed in those laws that they actually could regulate the certain aspects of ERISA plans when it came to PBM activities. And so in both of these cases, they were decided in favor of the states, and we submitted a amicus briefs to support these cases. We tracked and supported PBM reform bills in the states, including 10 plus explicit rebate pass-through bills introduced in 2022. I testified personally before the Georgia House Special Committee on Access to Quality Healthcare in support of Georgia House Bill 867, the Truth in Prescription Pricing for Patients Act, and that almost made it through the finish line, just did not quite get there, and we think it has a good chance in the 2023 session. We met and built relationships with a number of lawmakers in states who sponsored drug pricing reform legislation. We advocated before 20 plus congressional offices during our latest federal advocacy day in November 2021. We regularly submit comments to the federal agency, including the FTC, CMS, and other recent policies concerning the PBMs and drug pricing. And then we've definitely been involved in the media, in a number of op-ed pieces and getting quotes. I've been quoted a number of times in Heliorheumatology, for example. And then FSR, the Florida Society of Rheumatology, has a lot of influence and impact on ATAP. ATAP, I am the current president and have been the president since 2017, and Dr. Mike Schweitz is the president of the ATAP Action Network, which is our 501c4 lobbying organization that we formed last year in order to try to lobby both on a state and federal level for favorable and against unfavorable legislation. So with that, I'm going to conclude. Thank you for your attention, and I'd be happy to answer any questions.
Thank you, Dr. Levin. Really appreciate the talk. I think that most people are unaware of what's happening. And we have a few questions. The first one, I'm going to throw it out there, is that what's the difference between a PBM and how they function and how Enron function?
Yeah. Well, first of all, I think Enron's activities were illegal. PBM through Federal Trade Commission, you'd say, well, kickbacks are illegal. We're not allowed to, as physicians, we're not allowed to provide kickbacks for any service or pay a referral fee or anything like that. Well, the Federal Trade Commission gave them a free pass back in the early 2000s and allowed to set up the rebate system and are allowed to set up this pay-for-play system, which really made it legal. It's unethical, immoral, and is driving up prices, but it's really a horrible thing. And so I think that's the main difference, is their activities are legal, they're just unethical. And I think that, listen, I'm in a private practice. I fortunately am in a position where I own my practice. I'm in business. I'm not in business to lose money. I'm in business to make a fair profit. but I think there's a difference between profiteering and profiting. And I think the PBMs are an example of profiteering.
So essentially, the same actions, but they get to be saved by the government basically giving them a pass.
Yes, and I think that, a lot of these activities have gone totally unregulated because the PBMs just haven't had to, even in the states, register up until a couple of years ago as entities that were doing business in the state. So there was no basis to regulate their activities.
Okay.
A lot of states have passed that at this point.
I have a couple questions, and Kelly Skidmore has one. So let me ask you one, and then we'll get to Kelly. So recently, Congress passed the Inflation Reduction Act, and basically what they said is that they wanted to reduce the prices of drugs by forcing the manufacturers to pay even more rebates. So I wanted you to comment on that, because it seems to me that that's not the way to go. They need to tackle the PBM issue head on, other than just perpetuating the system by saying, okay, since they get them, let's get them too.
I think you're making a great point, Sean. It's not that's definitely not the way to go. I mean, the federal government is seeing, well, they could keep some of those rebates themselves and therefore decrease the budget deficit. And I just see that that's not really the way to go. The way to go is to regulate the PBM activities, which would ultimately lead to competition for who has the lowest price, not who has the highest price, and prefer those drugs.
Kelly, could you unmute yourself? So Kelly Skidmore, who serves in our House of Representatives in Florida, has a question.
Thank you, Dr. Baca. Dr. Levin, as an RA patient, having to get my monthly medication through a PBM, I spend hours and hours and hours of my time on the phone trying to get my medication, because the PBM often just puts a false barrier in place, suggests I owe a payment when I don't owe a payment, makes it harder for me to get my medicine timely. But is there anyone that I can file a complaint with in regard to that kind of consistent sort of malfeasance, if you will, so that we can raise awareness? And can we tell our constituents, our patients, how to do that when they are facing those same barriers?
That's such a good point, because there's all these barriers that we in the office try to overcome, and I know that my patients have the same problems. I don't have a great solution for you. I would say that I would file complaints with the Office of Insurance Regulation, since the PBMs are supposed to be and pharmacies are supposed to be regulated by the OIR in our state. And I would just file a complaint there, and I would write a letter to your insurer and the specialty pharmacy that you're getting the drugs from, and copy the Office of Insurance Regulation, and also I'm trying to think what other state agency would have jurisdiction over these pharmacies. But I think that that's one way to notify folks. I know the CSRO has what's called a map tool, and you can actually file complaints you can click on the map on your state and see what legislation actually might apply to the problem that you're experiencing, and then how to file a complaint or an appeal, and it's all right there. So you just go on the CSRO website and then click on the state of Florida, and you can see where exactly and how to file these types of complaints. But I really wish I had a great way to solve this, but unfortunately, the system is so convoluted. When you start getting involved with maximizers, accumulators, did the money that was provided by the manufacturer count towards your deductible? Or now they're saying you owe all this money because it doesn't, or any of this kind of stuff. it just makes it so convoluted and so complicated that I don't have a great solution. One solution that I do recommend is to talk to your doctor, because I know that I have manufacturer samples for when patients can't get their drug. And so if you call your physician and say that you need your whatever biologic it is, I've got samples of them, and that's exactly why I've got them, to start patients out and to be able to deal with insurance
Yes, I've had to do
hiccups that
that.
occur.
I've definitely had to do that, but thank you so much for that answer. I appreciate it.
We have another question regarding how do group purchasing organizations fit into this, and do they, contribute to the problem? I think GPOs, like United Rheumatology is one, et cetera, et cetera. So, so your thoughts?
Well, GPOs really are not part of dealing with specialty pharmacy drugs. They're really part of dealing with what's called buy and bill drugs. They're buying drugs and then basically, as a member of a GPO through Era Bencare, I get my drugs through our GPO, or we call it a CPO. But the bottom line is that those drugs aren't necessarily part of the rebate system and aren't affected or affecting any of this, at all. So I think that's a totally separate. These are, in terms of Medicare, these are Medicare Part B, and they are not being at this point. Although there are talks they're talking about possibly putting PBMs and specialty pharmacies as middlemen for Part B. That has not come into play yet. But in terms of Medicare, that's not an issue at all. For the commercial insurers, and then it's a different story. But still, the drugs are acquired at a certain price, and then the office is reimbursed at at a slightly higher price. Is how that works. So I don't think that GPOs or our CPO really are affected by much of this.
Another question is that essentially, my understanding is that the Affordable Care Act, which unfortunately didn't do much for the affordable part, basically wanted more vertical integration. And they capped the insurance companies at 18% profitability. So I'm assuming that if they're paying too much for the drug, i.e. the $6,000 price, and they're moving it over to company B, which is a PBM, which they happen to own, then that keeps them from hitting their cap. So is that what's going on here? Because then they can keep the insurance price high as well?
Yes, it's a shell game. I mean, they can, as long as the company themselves don't show more than 18% profit, then they basically they can put it off into some other subsidiary, and it doesn't count. So so they have designed workarounds so that they are not affected by these kinds of arrangements.
I'm seeing any other questions. Give anybody else a couple seconds more. You can raise your hand. Just a couple closing comments, and then Dr. Levin, I'll ask you for yours. This is a part of a series. We have two other parts that are going. This is recorded and will be on the Palm Beach County Medical Society website, but we intend to drive traffic to this so that people are aware of what's going on. We want the public to be aware. This is a service to the public, also our local officials, so they can understand what they're dealing with, because they are the solution to this problem, because this has to be regulated. It's just a total unfairness. And there's also a resource library in the website, as well as other resources to help you lower your drug costs. So the next one will be Tony Large, who is a lobbyist in Tallahassee who works with the Florida Society of Rheumatology and other groups, and they're talking about trying to regulate this. And then the last talk will be about the patient themselves, and how can you save money today? Yeah, and we'll talk about some tips and tricks to avoid some of these clawbacks and some of these other things to get around these problems so that you can get your prescriptions. So Dr. Levin, any closing comments?
Really just wanted to thank you and for your support on this issue, and thank all of you who spent the last hour with us to get educated on a very convoluted, complicated problem that is going to really require some very shrewd thinking and clear thinking to get at how to solve the problem. I don't have an easy solution, but I think if we can eliminate the rebate system, that would be a good start, and eliminating spread pricing. Basically, I think the PBMs should be paid a fair flat fee price for their services. And I think that would really, if they just had a flat fee for the services they provide, then I think that would be a win all the way around for healthcare. PBMs are basically this whirlpool, basically where it's like the money is being sucked out of the system down into the whirlpool. And as I said, they really don't produce anything. They don't help anything. They are just hugely profitable. And I think reining in some of this money, which is profiteered off of all of us, would really help driving down the cost of medicine and driving down the cost of healthcare.
Well, with that, I thank you so much, and thank you for your time. Personally, I'm going to actually give a donation to ATAP after this because I'm very impressed with them. And we wish you much success in your future endeavors. Thank you.
Thank you so much.
Good night.
Thank you, everyone.
Good night, everybody.